So I'm going to talk today about newborn screening for primary immunodeficiency disease. As you know, primary SCID is the most severe form of immunodeficiency, and typically those patients present with severe recurrent infection, chronic diarrhea, and usually they die early in life because of their severe infections. But luckily, they can be managed and cured by bone marrow transplantation or gene therapy. Its incidence worldwide is reported between 1 per 50,000 to 1 per 70,000 live birth. Its incidence in our country was not known till we did our study that we are going to present today. But we know in the high rate of consanguinity in the Middle East that range between 20 to 50% predispose our population to high incidence of genetic disorders, including severe combined immunodeficiency disease. If you look to our data, this is from King Faisal Specialist Hospital, you can see that SCID represents the commonest type of immunodeficiency. Almost 30% of our patients with PID are SCID. If you look also to the registries from the Middle East, and you compare it to the European Society of Immunodeficiency database, where combined immunodeficiency represents only 5 to 7% of their primary immunodeficiency, you can see that combined deficiency have a higher percentage in Middle East registries, ranging between 20%, like in Morocco, to 50% in the Kingdom, in Saudi Arabia. So SCID also meet many of the accepted criteria for to be considered for newborn screening. They are asymptomatic at birth, it's fatal without treatment, there is an effective treatment available, and early intervention improves the outcome. This is a data from Duke University. They looked to outcome of 169 patients with SCID, and it's clearly shown that patients who have been transplanted before 100 days of life, they have an overall survival that exceeds 95%, and their outcome significantly decrease with the age of transplant. Also, if you look to a data from UK, here you can see those cases who were diagnosed late. They have 48 cases. Their overall survival was only 40%, while their siblings who were diagnosed early in life because of the family history and they were offered treatment like bone marrow transplant or gene therapy, their overall survival was 90%. So definitely early diagnosis and early intervention will improve the outcome of such cases. To have a newborn screening test, it has to be inexpensive. It has to be you can perform. It is amenable to be performed on a larger scale. Should be very sensitive. Should be able to identify SCID with multiple genetic defects, and should take the advantage of the dry blood spot samples that are used in routine newborn screening, so that you can avoid having a new samples, and can be easily integrated into the existing screening programs. In 2005, Shan and Pak published their first publication regarding the usage of dry blood spots for newborn screening for SCID. They used TRIC assay, which is TRIC is a piece of DNA that are developed during T cell development, and it's a good marker for newly formed T cells. And this can be quantified through real-time PCR. In 2008, Wisconsin was the first state that started newborn screening. In 2010, the U.S. Secretary of Advisory Committee on Heritable Disorders in Newborn and Children in the state recommend including SCID as part of the newborn screening in the state. Now all the state performs newborn screening in USA. It has been also started in a few countries like part of Canada, Taiwan, Japan, Norway, and there's several pilot studies ongoing in Europe. If you look to the outcome, this is outcome of 3 million newborns screened in the state from 11 states in USA. They were able to diagnose 52 cases with typical SCID or Omen syndromes, indicating an incidence of 1 per 58,000 live birth. And the overall outcome of those cases, 92% are the overall survival post-transplant or enzyme replacement or gene therapy. In addition to the SCID, they were able to diagnose a non-SCID T-cell lymphopenia that are caused by several causes like DiGeorge syndrome, trisomy 21, ataxia, and there are several other possible causes for non-SCID lymphopenia. And all those cases would require also medical attention and would benefit from newborn screening. So newborn screening in the kingdom. So the question first, before asking for newborn screening to be introduced in the kingdom, is to try to assess the real incidence of SCID in our populations. So we conducted a study that aimed to assess the real incidence of severe combined deficiency in the kingdom. And also it was aimed to assess the feasibility of using targeted next-generation sequencing as part of newborn screening programs. And this was approved by Research Ethics Committee at King Faisal and was supported by CACS. To summarize our study, we have collected, as you know, newborn screening are done at King Faisal, also in Ministry of Health, and some of the samples that we received at King Faisal, we collected 8,700 anonymized samples after finishing their routine newborn screening, and we performed in-light trick assay for those samples. As you can see, most of the samples were normal. We used trick more than 36 copies per mil as our trick cutoff, and we'll talk later on why we choose this and what is the appropriate trick assay for newborn screening. In the first run, we have 315 that have abnormal result. Those have to be we repeat the trick assay. Most of them tend to be normal. So we end off with the 16 samples that are suspected to have SCID. Because we don't have access to those patients, we perform targeted next-generation sequencing primary immunodeficiency gene panel that contain 264 PID genes. And also we perform copy number variation analysis to rule out DiGeorge syndromes. And any predicted pathogenic mutations were confirmed through Sanger sequencing. So the results, in summary, we found 3 cases of SCID among the 8,718 samples, indicating an incidence of 1 per 2,900 live birth, which is almost 20 times the incidence in USA. And 2 suspected cases of DiGeorge syndrome. The mutations were in AK2, JAK3, and 1 very rare form of SCID, which is probably not a classical SCID, called MTHFD1, which is a metabolic disorder that associated with megaloblastic anemia, SCID, and neurological disease. But because of the high trick assay that we used, we were able to pick this case. So the question comes, what is the appropriate trick? We used 36 because we don't have access to those samples to perform immunological tests, and 36 was the cut limit recommended by the manufacturing company. But most of the states that perform newborn screening, so either in the USA or other countries, they use a lower cut up to 18 copy per mil. So we looked to the performance of this our assay with different cut limits. So this is the 35. As we mentioned, we have among the sample 16 were suspected. But if we drop the trick cutoff to 20 or 15, we will end only by 3. And those 3 will pick up all the classical SCIDs that are expected, and will miss the MTHFD1, which is expected. And for newborn screening, the main aim of newborn screening is to pick the classical cases of severe combined immunodeficiency. And it's important to use a very low, a reasonable cut of trick to avoid unnecessarily calling of patient or referral for patients with low trick that might increase the anxiety of parents and also increase the cost of such assay. For example, in the kingdom, if we do the newborn screening for our 570,000 newborns every year, if we use 35 cut limit, we'll have to evaluate 1,026 newborns. But if we drop to 20 or 15, we'll end only to 171 samples, our patients. 130 of them will be SCID, and 41 will be a non-SCID lymphopenia that will require further workup. And this can be managed and a reasonable number of referrals. So in conclusion, this is provide the first population-based incidence of SCID. We said 1 per 2,906, but if you talk about classical SCID, it will be 1 per 4,359 live birth, which is 13 times the incidence reported in the state. After this study, we know now the real incidence of SCID. To try to convince our health ministry about the importance of introducing newborn screening for SCID, I tried to do a cost effectiveness analysis for performing such tests. There is several factors in calculating the cost effectiveness or benefit of such newborn screening in our population that include the cost of managing SCIDs. For example, we know if you have a SCID that are diagnosed early in life, the cost of stem cell transplant, this is in USA dollars, is estimated 100,000. Those numbers of costs were calculated, we adopted from data from Duke University. They estimate 100,000 for SCID less than 3 months, and while the cost will be increased if you do the transplant more than 3.5 months to 450,000. Also, SCIDs who died without reaching a diagnosis or stem cell transplant will cost the health system, and it's estimated to be 300,000 US dollars. We know also important factor to consider for cost analysis is the mortality rate. We know if you have SCID with early diagnosis, the pre-transplant mortality is 6%, while late diagnosis is 22%. For post-transplant mortality, it's 6% for early diagnosis SCIDs and 31% for late diagnosis. The 1-year survival post-stem cell transplant is 94% for early diagnosis SCIDs and 66 to 69% for late diagnosis. It's important also to calculate the cost of such assay. The TRIC assay estimate cost per sample is around $8 US. 1.4% of all samples will require another repeat because of abnormal results, and this need to be considered as a cost. The positive screening test expected to be 0.03% for all samples. This is the number of referral, and as we mentioned before, it's expected to be 171 cases. And those will require clinical visit, flow cytometry. The flow cytometry estimate cost of $250 US, and the clinic $50 US. For those non-SCID, we require further work up and estimated to be around $6,000 US. So this table will summarize the cost and the outcome, cost benefits and the health benefit for the newborn screening. But before talking about newborn screening, we'll talk about our current states of SCID costs in our populations. If we assume that the SCID incidence is 1 per 4,359 live births, and we have 570,000 live births per year, this is the cost of the current state of our SCID status in the kingdom. We expect that we have 130 SCID per year. Now, currently, we diagnose only 25 cases. 7 of them, they were diagnosed early in life because of family history. So we end with 105 cases, they die with SCID in the kingdom every year without reaching a diagnosis and offering treatment. And those, they will cost, expected the cost of their management is around 31.5 million. Cost of early transplant around 700,000. For late transplant, around 8 billion. We don't do now newborn screening, so there is no cost. But the end of our SCID outcome, we were able to save only 18 cases of the 130 case, and 110 cases they die every year with severe combined insufficiency. And the overall cost is estimated to be $40.3 million US every year for SCIDs. So if we do newborn screening, still we have 130 cases every year. All of them will be picked up early in life. Still, we have some cases, 6%, they will die before offering stem cell transplant. But the other cases, the 122 cases, will go for stem cell transplant early in life, and their cost will be around 12.2 million. The cost of screening is estimated to be 4.6 million US dollars, including the repeat samples. We have 170 cases that require evaluations. The cost of their clinical visit, flow cytometry, and for non-skilled lymphopenia workup is around 250 US dollars. We'll end by having still cases died, like around 15 cases, but we'll be able to save 115 lives. And the cost will be only 19.5, or half the cost of the current cost of SCID in our populations. So definitely, if we conduct newborn screening, will improve the outcome of our patients, and we probably will be able to save from an economic point of view. But it's important to be able to manage such cases if we introduce newborn screening, and this will need to be discussed once we reach to the stage of approving newborn screening. By the end, I would like to thank all who contributed in the studies that include newborn screening lab at King Faisal, headed by Majid Dusugi, and others technicians that were involved in performing the studies, the Saudi Human Genome Project, and immunogenetic sections. Thank you.